Good morning, everyone. Before we begin today, I would like to acknowledge the traditional owners of the land we are standing on today, the Whadjuk people of the Noongar Nation, and pay our respects to elders past, present, and future.
Welcome and thank you for joining us today. My name is Vilma Fitzgerald and I am Senior Research Officer with the Australian Indigenous Alcohol and Other Drugs Knowledge Centre, which is located at the Edith Cowan University in Western Australia on the Mount Morley campus. Today's presentation is one of a series of webinars produced by the Alcohol and Other Drugs Knowledge Centre, which is funded by the Department of Health. I'm hoping everyone can see Veronica in full screen at the moment.
Good morning, everyone.
How are you?
Good, thank you.
Veronica, we are pleased to introduce our guest presenter, Dr. Veronica Boland, who is a postdoctoral research fellow with the National Drug and Alcohol Research Centre at the University of New South Wales. Dr. Boland has worked in the nicotine and tobacco research area for the last 7 years. Her research is focused on smoking and social disadvantage, where her work is embedded with high consumer engagement and aims to improve delivery of new and enhanced evidence-based cessation strategies for disadvantaged smokers. So good morning, Veronica.
Good morning, Vilma, and thank you very much for that introduction. That was fantastic. And welcome, everyone. But yeah, I can give a little bit of background about myself to the audience. So I started at the National Drug and Alcohol Research Centre in 2012, working on a quit smoking study, which I will be talking about today. And I was a research assistant, and that trial actually left me with more questions than answers. And so then that led me to conduct a PhD in an attempt to answer some of the questions. And today I'll be talking a little bit about the qualitative work that I did as part of my PhD. And then continuing that focus, I will end with a study that I'm involved with at the moment, and that's looking more at electronic cigarettes as a potential cessation strategy. If you do have any questions, as Wilma said, just keep them to the end of the presentation. And if you aren't too shy to ask the question, I'm happy to take emails at a later date. But I'll just hide my face, and then you guys can just look at the presentation slides. Okay, so I have no declarations of interest that I need to declare. And I thought I would just start off with essentially 3 take-home messages if there's 3 things that you want to take home today. And it would be that health risks are almost completely from tobacco smoke, as opposed to nicotine, which was commonly cited in my qualitative work, that I did focus on socially disadvantaged smokers, and nicotine was perceived to be the harmful product, but it's more tobacco smoking that we should be worried about. And so we should be encouraging smokers to completely quit smoking, because just smoking 1 or 2 cigarettes per day is associated with cardiovascular risks. And when we look at nicotine replacement, we can consider that as a harm reduction approach. So when we look at the disease burden in Australia, there are about 3 million smokers aged 14 or over. And when we look at social inequalities, socially disadvantaged and low-income groups are not quitting at the same rate as other Australians. So there is scope to really focus in this area and to help those who are carrying the greatest burden of disease. The social costs annually are massive, and when we're looking at low socioeconomic status or socially disadvantaged and vulnerable groups, spending about $30 on a pack of cigarettes is really pushing the budget. Now, when we drill down and look at smoking and disadvantage, the National Drug Strategy Household Survey found no significant change in the Australian smoking rates, despite multiple and prolonged tax increases. And that's between 2013 and 2016. So we definitely do need to do a lot more to try and encourage smokers to try and quit and to successfully stay quit. And then when we look at the disadvantaged population groups, so they're disproportionately higher smoking rates. They suffer from more tobacco-related diseases, discontinue pharmacotherapy treatments and behaviour support earlier, and they face additional challenges when quitting. So some of the barriers that are cited in the literature is that this group tend to be more nicotine dependent. They tend to have a social network of smoking, so that means that their close friends and family are smokers. They do encounter multiple stresses. Retail density and access to cigarettes is higher in low-income areas, and the ability to adhere to medication is what makes a quit attempt successful. But in this group, they tend to stop medication prematurely. When we look at financial stress, smokers with high financial stress are less likely to quit. Ex-smokers with high financial stress are more likely to relapse. So I'll talk a little bit about the study that we did when I first started at NDARC, and that was really trying to target financial stress as an intervention to increase cessation. When I did look at the literature for Aboriginal specific barriers to quitting, I came across personal, social, cultural, and environmental factors. So again, there's a little bit of crossover between what I've found in my research and what others have found with Aboriginal specific barriers, and that includes stress, so multiple life stresses. Grief, so smoking related bereavement is generally having a family member or close friend that has either suffered health effects, so either death or severe disability from smoking. Limited knowledge about quitting, lack of culturally relevant quitting resources, the social pressure to smoke, and the social exclusion when quitting, so that does tie into the social context of smoking, and a lack of role models. Now, when we're looking at current treatments and services available in Australia, the behavioural support that we would recommend smokers to turn to would be Quitline. However, among smokers, uptake is extremely low. So we're looking at around 3% in Australia. And in the United States, they report about 2% of smokers using the Quitline. The pharmacotherapy or medications that we can recommend smokers to quit is essentially Champix, nicotine patch, and Zyban. However, they do cost the health system quite a lot. And as noted previously, discontinuing prematurely is common among disadvantaged and vulnerable populations. So they're not getting the most out of the prescription medications that we offer. I did find some Aboriginal specific resources and services, and they're using more technology-based platforms. So Deadly Choices, it's an online resource, and the Can't Even Quit mobile phone app that's being developed. That was also something that I came across. So that may be of use to some people in the audience. Now, looking at cessation interventions targeting disadvantaged groups in Australia, overall there's a limited number of Australians RCTs, and you can see the population groups that it's either social services, mental illness, or Aboriginal and Torres Strait Islander individuals. There was a systematic review that was conducted where they were looking at the quality of the studies in among disadvantaged groups, and it was cited that the quality of the studies was overall quite low. Now, this brings me to the financial education RCT that I worked on. So it was actually called the Financial Intervention for Smoking Cessation Among Low-Income Smokers. To lay people, we called it the Supporting Smokers to Quit study. And this was a study that really got me involved with smoking and disadvantaged and vulnerable population groups. The aim of this study was to test the efficacy of a financial education and support program with 8 weeks of free combination nicotine replacement therapy. And the aim was at reducing financial stress and increasing smoking cessation among socioeconomically disadvantaged smokers. So we used Centrelink as a proxy for socioeconomic disadvantage. Participants needed to be 18 years or over, and they needed to smoke at least 10 cigarettes a day. The nicotine replacement therapy that we provided, it was for free, and we provided nicotine patches, and participants could choose either nicotine gum or lozenge to help with their quit attempt. And that's cited as a barrier in the literature, that access to medication costs too much and prevents low-income groups from accessing. So we did try and overcome some of the barriers that the literature does cite. Now, if you want more detail about the method of that study, I'm happy to forward you the protocol paper, but I'll just go on to the demographics. So we had an average age of 46, so of 1,047 participants that we recruited, their average age was 46. 53% were female. We did have 7% identifying as Aboriginal or Torres Strait Islander, and 57% had a partner or spouse that smoked, and 41% reported most or all of their most of their closest friends, are smokers. When we look at the financial aspect to this sample, they were spending about $90 a week on tobacco. 85% were unemployed, and more than one person who was on a Centrelink payment was cited as 73% were reporting that. Now, when we look at the financial stress component, which we did try and intervene with, so each participant that was in the intervention arm received 4 telephone support calls where we delivered financial education and support, so things like budgeting, goal setting, and trying to find ways to get on top of bills and reduce tobacco consumption. So when we look at the results, 53% of the sample had asked for financial help from friends or family. And the one that stuck out to me was 43% went without household essentials to pay for cigarettes. And that trial finished up in 2015. So it would be really interesting to follow up now to see, after the tax increases, how that has played out. When we look at the results, like overall, we had a high retention rate. So 84% of participants completed their final follow-up. When we look at the treatment outcomes by the intervention and control arms, there was no difference. So that did leave me with a lot of questions about, well, we did try and address some of the barriers, such as access to treatment, providing behavioural support, but overall there was no difference. So that led me to do qualitative research with some of the participants that took part in this study, and I have published it, and that was part of my PhD. And so the aim of the qualitative study using Fiscal's participants was to explore their recent quitting experiences, to assess the factors that impact treatment engagement, and examine the acceptability of alternative smoking cessation support. So what I was really interested to find out was essentially what they liked and didn't like about what we delivered. What are some of the alternative treatment options that they might consider or be receptive to? And then what are the factors that really influence how they engaged with their quitting behaviours? So I interviewed 5 ex-smokers and 19 smokers who were located within the Sydney region. And I did do a thematic analysis. Again, if you want more details about that paper, I'm happy to forward that on. So the results from that qualitative study was quite interesting. So this was around the time when the tobacco tax increases had really taken effect, and a lot of the smokers were reporting smoker-related stigma. And so that was around guilt and shame. So it was the guilt and shame that they felt from externally from society with the changing social norms from smoking, as well as the guilt and shame that they felt from spending money on tobacco, which meant that they couldn't spend money on either their children or grandchildren, or they were getting behind in bills, legal costs and whatnot. And so that really negatively impacted treatment-seeking behaviour. Again, looking at identity, so whether someone had a positive smoker identity or an ex-smoker identity, that had really interesting implications. So identity was a motivator that promoted or undermined quitting. So for an ex-smoker, ticking the box of non-smoker served as a motivation to continue with their no smoking rules. Positive smoker identity, that was a lot more challenging because a lot of the smokers that I spoke to were talking more about that social context of smoking, where so much of their life is centering around smoking, meeting up with friends for a coffee and a cigarette, sitting down with family, and just part of the conversation does involve smoking. And then when I was looking at the quitting strategies, that definitely differed by identity again. So ex-smokers were very strict with their non-smoking rules, and they applied them to everyone. So friends, family, peers, whoever it was, if it meant that there was no smoking in the house, that meant everybody had to go outside and there were no exceptions to the rule. However, if you had a positive smoker identity, it still allowed smoking as permissible. So it would require hiding cigarettes in the shed out the back, but still being allowed to smoke, or delaying the time at which you would have a cigarette. So maybe only limiting it to 3 a day when they're meeting up with their friends. So that was quite an interesting finding and has got me thinking about how do we intervene with the identity of being a smoker and transitioning into ex and non-smoker identities. Another aspect to the qualitative research that I found was regarding quit support services and what are possible alternatives to Quitline. So many of those who I spoke to, they hadn't really engaged with Quitline, but they weren't motivated to try from that point in time. So we did discuss the possibility, everyone had a mobile phone, and the possibility of using mobile phone platforms. And so using text messages, apps, websites, they were definitely seen as more something that they would prefer over calling Quitline and speaking directly to a counsellor. Often it was cited that calling a counsellor made them feel in a way ashamed, and they didn't want people within their wider social network to know that they were trying to quit. So having mobile phone based behavioural support was something that they preferred because they could engage with it when they wanted to and when they were ready to. So another aspect of looking at technology and quitting, we did discuss the use of e-cigarettes, and they were perceived as unsafe due to their legality, lack of information about use, safety and efficacy. However, they were willing to try if they were offered an e-cigarette. So that was quite interesting. And I think more information definitely does need to be provided. And I'll talk a little bit further down about the trial that I'm currently involved in that may assist this population group. So these are 4 quotes from the qualitative work that I conducted. The yellow quote's more about the identity. So a person cited that they felt that smoking was just part of their identity and that it was part of their personality or something. So the thought of never smoking again was quite unfathomable. The green box is more about the stigma that was experienced. So one person cited that they were essentially screamed at while they were walking on the street because they were smoking, and the person was sitting at a restaurant and didn't like that they were smoking. The red box is more about the Quitline, perceptions around Quitline. Oh, sorry, no, not Quitline. That's the grey box, sorry. The red one's more about using text messages. So they definitely wanted some kind of interaction, and they would be willing to try it. And then Quitline, again, it was just something that people weren't comfortable accessing. So I'm not sure how many of you in the audience are familiar with e-cigarettes for smoking cessation, but I'll talk a little bit more about the postdoctoral fellowship that I've been involved with. So as you can see on this screen, there's the 4 different types of e-cigarettes. So there's the first generation that looked like a cigarette, and most people don't really use them these days. They did shift to tank devices. So you can see the glass top bit, that's where you put the e-liquid, so nicotine e-liquid. And if you look at the pod one, it looks more like a USB stick, and the flavors are on the other side where they're secured by magnets and they're pre-filled pods, and each pod is about one pack of cigarettes. So they're definitely evolving, and different people prefer different types, but there isn't an awful lot that's been done with looking at vaping on quitting outcomes. So when we do look at e-cigarettes, they have the potential to provide a clean source of nicotine. They can deliver nicotine swiftly and effectively to reduce nicotine withdrawal symptoms. They do cost significantly less than tobacco, and so far they appear to be less harmful than tobacco, but we do need to consider that most vapers are current or former smokers, and while there is currently no evidence that vaping is associated with disease, the e-cigarettes haven't been around long enough to observe this association. So we do need to tread with a little bit of caution and definitely have our research collecting data and reporting any associations if they do show themselves. The current evidence is, as I said, quite limited. So there are 3 RCTs that have looked at e-cigarettes for smoking. We do need more data. And the NHMRC CEO statement in 2017 stated there is currently insufficient evidence to support claims that e-cigarettes are safe, and further research is needed to enable their long-term safety, quality, and efficacy. And that does us to the study that we're doing here at NDARC, and we're trying to answer that statement. When you do look at vaping in Australia, you need to be mindful that devices are legal to purchase, not to minors. Nicotine is a Scheduled 7 dangerous poison unless approved for therapeutic use. So that's either in nicotine replacement therapy or in tobacco prepared for smoking, such as cigarettes. If a client does want e-liquid that has nicotine in it, you are required to have a valid prescription, so it's a class as a Schedule 4. It needs to be prepared from a compounding pharmacy. If it is purchased online, the TGA, so Therapeutic Goods Administration, has under the personal importation scheme, allows 3 months supply at any one time, but you do need a valid prescription. So this brings me to the randomised clinical trial where we're comparing e-cigarettes to nicotine replacement therapy for smoking cessation among low socioeconomic status smokers. So this study is currently in the startup phase, and I'll just outline what we're hoping to achieve. So the aim of the study is to assess the effectiveness, safety, and cost effectiveness of e-cigarettes compared to nicotine replacement therapy on 6 months verified abstinence among low-SES Australian smokers. So we will need to recruit around 1,058 smokers. We will be recruiting via print and online advertising, and we do have multiple data collection points to try and assess the effectiveness, safety, and cost effectiveness, and that's in the form of a baseline and 7-month follow-up interview conducted by an independent contract research organisation. We also will be looking at safety and adherence to e-cigarettes and nicotine replacement therapy, and that's via 2 telephone check-in calls with the NDARC team. And we will be using data linkage with the medical benefit scheme and the pharmaceutical benefit scheme to look at the long-term safety and the health economics and the cost effectiveness. So the eligibility to participate in this study is as follows. So inclusion criteria, you need to be on a government pension or allowance, so that's a proxy for low socioeconomic status. You need to be at least 18 years of age or older. You need to be a current daily smoker who wants to quit using nicotine replacement. So either I've got here VMP, which is a vaporized nicotine product, or e-cigarette, or nicotine replacement therapy. Participants will be providing verbal consent, and they need to have a telephone so we can conduct our data collection interviews. The exclusion criteria includes anyone who's pregnant or breastfeeding, currently using medications to help them stop smoking, participating in another quit smoking study, or having been hospitalised for heart attack or a stroke in the last 2 weeks. So as I stated previously, there's the intervention and control arm. The intervention arm we will be providing for free 2 devices plus 8 weeks supply of nicotine e-liquid, and we'll be providing a mix of tobacco, menthol, and strawberry flavour. And in the control arm, they will receive 8 weeks supply of nicotine replacement therapy. So that does include their preference, so they can choose gum or lozenges. And again, we're providing that for free of charge. The outcomes of interest for this study are to assess the differences in adverse and serious adverse events by the treatment group. We want to assess differences in the verified abstinence by treatment group. So that's looking at the nicotine group, the NRT group, and the e-cigarette group. And we will be doing a carbon monoxide breath test. The implications for this study will provide evidence for the role of e-cigarettes on quitting outcomes and provide cost effectiveness of e-cigarettes compared to nicotine replacement therapy, as well as providing much needed safety data on the use of e-cigarettes compared to nicotine replacement therapy. I can talk a bit about our feasibility study. So we're in the process of finalising the feasibility study, where we recruited 27 participants. Of the 27, the average number of cigarettes they smoked per day was around 22, and 96% had previously tried to quit. And in the feasibility study, we were testing 3 different devices to see which one was the most acceptable. And what we found was, so that all three were tank devices, and we found that the easier the device was to assemble and use, it was more common for them to cite that as the device that they liked, the one that they would recommend to the researchers to use and to their friends. What was interesting is the flavors. So a lot of the 27 of the feasibility opted to have tobacco liquid flavor, but after using it, they preferred another flavor. So more for the main trial, we will be using a mix of flavors, and so that allows each individual to personalize their quitting using a vaping device. What was quite striking was the vaping is very different to smoking a cigarette, and I was trying to educate the participants that it is different, but it doesn't mean that you give up straight away. Just like the first time they smoked a cigarette, it would have taken a bit of practice. This is the same with smoking an e-cigarette. It is different, and it's got a different feel, and it does take a little bit of practice. So perseverance is definitely key when trying to quit smoking. So for this trial, we hope that we will contribute to a regulatory framework that is based on evidence-based research. And the outcomes of this study may lead to the adoption of e-cigarettes as a cessation aid. And it may be a strategy that is more acceptable to disadvantaged and vulnerable population groups who smoke at higher rates and encounter multiple barriers when trying to quit smoking. So that does actually bring me to the end of the presentation, and I would like to acknowledge NHMRC for funding our projects, and to the NDARC research team and investigators, and also to the funding that supports the National Drug and Alcohol Research Centre. So if anyone has any questions, I'm happy to field them now. Don't be shy. If you are a little bit shy, you can see my email address is at the bottom of this page, and I'm happy to get in. I'm happy for you to get in contact with me. So yeah, thank you.
Thank you, Veronica, for your presentation. That was really interesting and informative. We now have an opportunity to take some questions. If you would like to ask Veronica any questions, please type them into the chat box, which is located on the bottom right of the screen. It's the purple pull-out menu, and you'll see a bubble chat icon, and we'll answer them as they come up. And if you do have any questions and you prefer to email her, please feel free to do that as well. So we'll have about 5 minutes for questions if anyone would like to ask anything. Okay, so this is from Ash. Just wondering if you have any thoughts on secondhand e-cigarette vapor. The World Health Organization, WHO, recently said that the aerosols from e-cigs typically contain toxic substances and can pose a risk to non-users. Have you come across anything about this in your research?
Well, currently I haven't come across the second-hand e-cigarette vapor. I should have probably noted to everyone that the deaths associated with e-cigarettes in the States has been associated with THC oil being mixed with vitamin E oil, and so that's led to deaths because you should not be inhaling oil. But regarding the secondhand e-cigarette vapor, Ash, if you're okay, I could do a little bit of investigating and get back to you. Would that be okay with you?
Yeah, Ash, if you would like to provide your contact details,
you can email me or
I'll forward those on to Veronica. So if you want to email it to my email address, v.fitzgerald@ecu.edu.au, I'll get that response back to you. Thank you, Ash. We have another question from Sarah. Do you have any more details on quitline use in Australia? Examples, state-by-state breakdown. Some states have web chat too. Wondering if this was included.
Yeah, so I don't actually have the breakdown by state. I do know that Victoria has access to text messaging and mobile apps, but it's not available in New South Wales. And I think that would be really important to expand that out. I do think though, particularly with Aboriginal focused quitting, we do need culturally appropriate services. So that's something that I think there are some people at the Cancer Institute New South Wales that might be looking into that. But with the quit line, yeah, we do actually have another study that will be starting up later this year that's looking at text messaging compared to quit line, and that we are hoping that we can get the breakdown of the quit line use across the country. So I can answer Chris's question about what did you have to do for ethics, for which study? So the fiscal study, my qualitative, or the e-cigarette one? The e-cigarette one's been quite challenging because yeah, so that's been quite challenging because we need to. It's been quite. So we need ethics approval from UNSW. We need to have a clinical trial registration for a CTN. And we needed to make sure that all of the products that we are wanting to provide participants, they needed to comply with good manufacturing practice. So we needed to have all of those certificates. And with the e-liquid, we need the emissions testing data to make sure that what we're giving participants is produced as close to a medical grade as possible, because internationally it's not marketed as a prescription medication. So that's what we've had to do, and we needed to also get ethics approval from the Department of Human Services to do the data linkage. So if Chris, you wanted to contact me personally, I can go through the steps in more detail. But yeah, for ethics, it has been quite a challenge to comply with everything, because Australia's in a bit of a grey zone with how we classify e-cigarettes. And the tricky thing was, if we were providing e-cigarettes just for recreational use on the TGA website, we wouldn't have needed a CTN. But because we're providing it as a smoking cessation device, you do need a CTN, and trying to get all of the data from the companies has been quite challenging. Do you know if there are any targeted funding rounds coming up to support Aboriginal women smoking during pregnancy due to high rates? I'm not sure. The funding rounds, it depends on who you apply for with funding. But to my understanding, that there is a group at Newcastle University that is looking at this. So that's, I think it's with Gillian Gould. I can potentially email you, Jessica, if with those details, if you're interested in hearing more about that study.
Doesn't look like we have any more questions. So our contact details will be coming up on the slide. So that's our contact details. If you wish to contact Dr. Veronica Boland directly, or if you have any other questions or want to find out about upcoming webinars, you can contact myself, Vilma Fitzgerald. Now we'll just go to the next slide just to give some information about our tobacco website on the AOD Knowledge Centre, and the other topics that we cover and how it affects Aboriginal and Torres Strait Islander people communities on the AOD Knowledge Centre. And you'll find tobacco key facts, key resources, as well as subtopics which are highlighted in blue in the right screen, such as prevalence, prevention, education, regulation and control, as well as treatment and support. And we also have, I'd like to do a quick mention about our review of cardiovascular health among Aboriginal and Torres Strait Islander people 2019 is now available on the Australian Indigenous HealthInfoNet website. And the review summarises the most comprehensive and up-to-date information on the Aboriginal and Torres Strait Islander cardiovascular health. So, and a publication is available to view or download as either a review, a short video, or an infographic fact sheet. And also like to mention that the Alcohol and Other Drugs Knowledge Centre is currently working on our tobacco review, and this should be available in the future soon. Thank you everyone for joining us today and being part of this AOD Knowledge Centre webinar. And a special thank you again to you, Veronica, for that great presentation. We really appreciate it.
Well, thank you very much, everyone, for taking the time to listen to me. I appreciate it.
That was a good turnout today. And please note that our webinar will be available as a recording and a PDF handout in the future. If anyone has any feedback or would like to forward some questions or queries, then please contact us. Make sure you subscribe to our monthly newsletter for our latest updates and news on AOD, and to find out when our next webinar will be on, so stay tuned for that one as well. So thank you everyone, and have a great day.
Yep, thank you everyone.
Thank you, Veronica. See you soon. Bye everyone.